Welcome to all of you in this celebration of World Pneumonia Day. My name is Bill Moss, and I'm the Executive Director here at the International Vaccine Access Center. I really am very excited to welcome you to this World Pneumonia Day event titled Maintaining Progress on Childhood Pneumonia in the COVID-19 Era. The International Vaccine Access Center celebrated its 10th anniversary last year. We're based within the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And our mission is to accelerate equitable access to vaccines through the generation, synthesis, and use of evidence to inform decision-making and action. We consist of a multidisciplinary team of physicians, epidemiologists, economists, communication specialists, and advocates. This year, we're particularly interested in promoting and raising awareness around pneumonia. Pneumonia remains the leading cause of childhood death around the world. And this and any progress that we've made, and we've made substantial progress, is currently being threatened by the COVID-19 pandemic. IVAC has long been an advocate for action on child pneumonia. Back in 2009, IVAC helped establish the first World Pneumonia Day. And each year, IVAC analyzes global progress toward meeting goals to prevent child pneumonia. This year's Pneumonia and Diarrhea Progress Report shows some bright spots, but again, we're concerned about lack of progress due to the COVID-19 pandemic. That's what we're going to discuss today with our panel. Again, I welcome all of you, and we'll turn it over to our moderator, Cynthia Gorney.
Welcome, and thank you all for joining us for this World Pneumonia Day conversation about fighting pneumococcal infection in children and the progress and ongoing challenges in making these new vaccines available where they're needed most, especially during this extraordinary COVID year. IVAC and the Johns Hopkins School of Public Health have again brought together this great panel of experts to help bring us up to date and answer your questions over the next 90 minutes. I'm Cynthia Gorney, as Bill Moss said, and as a National Geographic writer, I was lucky enough to learn directly from a couple of these panelists while working on a 2017 story that focused on the work of Dr. Shamir Saha in Bangladesh to help explain why pneumococcal vaccines are still such a crucial issue for the world's children. So I'll introduce each of these panelists as they tell us some of the important changes these last couple of years have brought. And then I'll help field your questions for them. You should see a chat box below, and if you'd like to introduce yourself, and as Andrew said, a separate Q&A box for your questions. So Andrew's going to try to help me field some of your questions once we've heard a little bit from each of our panelists. So Shamir Saha, as I just mentioned you, it's good to see you again, even this way. Dr. Saha heads the microbiology department at Dhaka Shishu, which is the biggest children's hospital in Bangladesh. He also directs the Child Health Research Foundation there, and for decades, he's been a leader in research on pneumococcal pneumonia. Dr. Saha, could you start by helping us with a global overview? We're all overwhelmed by COVID statistics this year. It's too easy to lose track of other important numbers, right? How many children worldwide are still dying from pneumococcus infections? As one of our participants to this conference asked in advance, are we winning this war?
I think we were almost, at least mentally, or maybe confidence-wise, we are thinking that maybe we may differ the time, but we're thinking that we are winning the pneumococcal pneumonia or pneumococcal diseases. But overall pneumonia, I'll be coming that later, but I can tell you that COVID-19 can really delay us a lot, that we are understanding, because if you look at the EPI program at different countries, gradually those getting hampered. For example, say Bangladesh, I can give you the example because it is one of the country which is known as that it is one of the best EPI system we are running there. But unfortunately, when the COVID-19 started, immediately the overall EPI coverage, vaccine coverage dropped.
Why
So
is that? Why is that, Dr. Sutton?
all those are, I mean, this because people are, there is a stigma. In fact, nobody was going out, number one. Number two, the lockdowns were there, those are another thing. But also consider that EPI in Bangladesh, they really always go forward to really help any kind of disaster like this. So the EPI team of Bangladesh, they really helped to collect the specimens, to really transport the specimens from the collection place to the laboratory. All those are done really by EPI program. And even the transports, which would the EPI team was using to take the vaccine package to one place to other, those were being used, in fact, for this COVID this specimen collection. So all those the vaccine coverage was reduced significantly, in fact, especially in the urban area, because where the diseases were more, the COVID diseases were more, and that is the reason really people were not really going out. And also our urban EPI program is relatively weak all the time because it is being managed in a different way, not by the EPI itself. So those are the problems as well. But gradually I can tell you, we are gradually catching up and we are doing much better. But I can tell you the campaign, for we always do campaigns, for example, the measles campaign and other vaccine campaigns, those are not really done yet. The vaccines are ready, vaccines are being delivered to the rural area, but they're still remaining there because we cannot really do that campaign anymore. So because we are just afraid that may really happen, what really happened in maybe in US or many other countries. So we are really facing problem. I believe we'll be delaying. I mean, our path will be not really as fast we are moving as it will be, but hopefully we'll be overcoming this. Yeah.
Thank you. Let me turn to Dr. Keith Klugman. Hello, Dr. Klugman. It's good to see you again. He's director of the Bill and Melinda Gates Foundation's pneumonia program, and he spent years studying pneumococcal pneumonia and how the vaccines have worked. Dr. Klugman, could you start by telling us about the new PCV that's been developed in India, Pneumococcal, and why this matters so much?
Sure, Cynthia. So the problem that we've had so far with the rollout of pneumococcal conjugate vaccine is several-fold. One is that some of the biggest countries on the planet, in terms of the number of children, have not introduced. And the constraint there was either cost or, in the case of India specifically, a fervent desire to have a vaccine that was produced in India. So fitting in with what Shamir said, the key problem we're facing now with regard to COVID is in two large countries, that is India and Indonesia, where coverage has not yet rolled up significantly. India does have vaccine that was introduced, in fact, paid for by Gavi, and this is one of the multinational vaccines. But the rollout across India was waiting for a local vaccine, and obviously COVID has slowed that a bit. And then follow up that Indonesia too, there's optimism, but the distraction of COVID is slowing it down there too.
Has Pneumococcal come into India, sort of catch us?
No, not yet. So it is licensed, but has not yet been used. One of the issues is that India uses a 2+1 schedule. This is a little bit technical, but they're still getting evidence on the 2+1 with the new vaccine. The key thing with the vaccine, the new vaccine, is that Gavi, which really has done an extraordinary job in rolling out PCV globally, is spending half of its total budget of vaccines just on pneumococcal conjugate vaccine. So the introduction of the new vaccine made in India at $2 a dose to Gavi countries, reducing the price of the vaccine by about a third, is a game changer in terms of the affordability. But it goes beyond Gavi and poor countries. There's something called a middle income gap, where a large number of countries that have to purchase vaccine themselves, in other words, they can't purchase the vaccine through Gavi and UNICEF, have been excluded because they couldn't afford the $12 plus cost of the existing vaccines per dose. And so 3 doses, you can multiply up what the cost is per child. And we're hopeful too that the introduction of this new vaccine, if it is made available at a more affordable cost in these middle income countries, and certainly Serum Institute have indicated they intend to do that, I think this could be game changing for the availability of PCV for children, poor children in these middle income countries too.
I'm going to ask you one more question about Serum, and we'll definitely come back to that later. Serum, if I understand it correctly or remember, Serum was working on this new PCV before anybody had heard of the novel coronavirus. What do you know about any complications that might occur in their rollout schedule, their production? They are, I believe they're also working on a coronavirus vaccine, right? So is there a chance that this isn't going to be an ongoing theme, I know, in this morning's discussion, but that resources, attention, distribution could be distracted by their need also to work on a COVID vaccine?
So obviously this is a theoretical problem. I have not heard anything. You know, we would have to ask the company themselves. So far, we've had no indication from Serum. I mean, that company has stepped up, as have all, in fact, the private vaccine manufacturers, in quite a remarkable way. And I think it's public domain that the Gates Foundation is working to try and help COVID vaccine become more widely available to people in developing countries. And the Serum Institute will be one of the manufacturers that have committed to make millions of doses of vaccine. But so far, we have not heard that this has impacted in any way their plans to scale up PCV, and hopefully there will not be a problem.
Okay, so that's going to bring us next to Anurada Gupta, who is the Deputy CEO of Gavi, the Vaccine Alliance, which of course is the international organization that's helped bring so much lower cost vaccine to millions of kids in developing countries. She's also the former mission director of India's National Health Mission. So I'm going to ask you a Gavi perspective version of the same question, Ms. Gupta, which is, how has the pandemic affected global efforts at vaccine distribution?
Yeah, so first of all, if I talk about pneumococcal conjugate vaccine, I do think there is a lot to celebrate. So we just saw that those compelling stories from Nepal, and the fact that now poor countries have equal access to a very complex and costly vaccine like PCV, I think is a remarkable achievement which needs to be celebrated. And so Gavi has been able to support 60 countries. India, of course, is one of them. But of course, India has to then scale it up with their own domestic resources. And I think today we are at that juncture where coverage of PCV is actually higher in Gavi countries than the rest of the world, which I think, again, is very, very spectacular. And of course, we also see that with improved use of this vaccine, the use of antibiotics can actually be prevented. And we just saw how when children are stuck with pneumonia, and the hospitalization costs for some of the poor families can be very, very high. So I just wanted to take a minute to reflect on huge progress that we see on this front, particularly PCV. Now, SII entry in PCV market has indeed changed the game.
For those who aren't familiar with Technology. What is SII?
So Serum Institute of India. This is the manufacturer that Keith was referring to. So this is the third manufacturer to enter the PCV market, and that indeed, has broadened the choice of products and presentations for countries, but it has also brought down already the price of PCV by 30%. So I think that's a very good sign. Now, coming to the pandemic has actually impacted routine immunization a lot. And we have seen widespread disruption of services, particularly outreach has been hit, which really means that when outreach services are not up and running, the most marginalized populations would be impacted. And I think from pneumonia perspective, that is extremely, extremely important because it is really poor families living in insanitary conditions that are at the highest risk of pneumonia. And if they fall off our radar and they don't have access to multi-sectoral interventions that are needed, then clearly the risk is exacerbated.
Is there any possibility that the distribution and promotion of this lower cost Serum Institute vaccine could impact negatively the production by the multinational companies in just saying, well, look, we can't make enough money on this, so let's leave it to Serum to take care of everything. We're out. We're going to go produce a vaccine that makes us more money instead?
So we will see how the market plays out on this. But this is a very pertinent question. I think in vaccine markets, we got to be very careful that we can aim to reduce prices up to a point. But if we are solely focused on price reductions in vaccines, it can sometimes be counterproductive. So at Gavi, we are increasingly talking of healthy markets framework, which really means that apart from price, we also make sure that we pay attention to uninterrupted supply of vaccines, diversification of market, innovative products that are appropriate to country settings so that we are actually able to meet the choices that the countries may have.
Dr. Klugman, I'd like you to hold that thought just for a moment until we get done with everybody starting off. But please do hold that thought because I know you have a lot of strong opinions on this matter. Thank you, Ms. Gupta. I'd like to next introduce Brian Patenaude, who's a health economist who teaches at Johns Hopkins and is a PI for a project called DOVE, the Decade of Vaccine Economics. Dr. Patenaude, you've been studying the economic impact of illness in Bangladesh and Uganda, correct? What does this work help us understand about vaccine distribution, both pre and during the pandemic?
So what it helps us understand is who is receiving the vaccine in these populations, what subsets of the income distribution. So we talk about in high income countries a lot, or particularly the US, you think of like top 1%, bottom 99%. When we're talking about the bottom 20%, the top 20%, some in the middle, and how they're both receiving vaccines, but also the benefits that are being accrued to them and the impact that receiving that vaccine is having on their lives. So one of the things we look at, particularly you saw in these videos that were presented before we started talking, is sort of what is the impact on people's everyday life from suffering a case of pneumonia? And how does that translate into dollars spent? How does that translate into impoverishment and things like that? So we've taken a deep dive into a subset of individuals in Uganda and Bangladesh across all levels of facility and all types of treatment for pneumonia to see how much a case of pneumonia is burdening families, both in terms of medical expenditure, but also transportation, travel, and staying at a facility that may not be near their house for inpatient visits, anything that needs to be done for follow-up to treat the case of pneumonia, forgone labor and work that needs to be done to take care of a sick child. And we've calculated this out and we find out that caregivers in both—
Dr. Patenaude, are you surprised by what you're finding? What is the most startling?
The most startling is the degree of burden on the bottom 20%, particularly. So we're seeing that up to 70% of households in the bottom 20% are going into poverty from a case of pneumonia. They're not able to borrow money to deal with this. They have to sell assets. It takes up way more than 40% of their expenditure, excluding food. It's a very large amount. And so people are finding different ways to cope with it, but a lot of that has to do with selling assets and going into debt to take care of these cases, whereas in the upper quintiles, 95% of people can pay for this with savings.
Is COVID complicating this picture? And if so, how?
COVID's complicating the picture because people are having additional costs associated with dealing with COVID for those who get COVID, but also vaccines aren't being delivered. We just talked about there's disruptions in vaccinations. So what we're measuring in these expenditures are costs that are incurred because of a case of pneumonia. Because we're not vaccinating, those cases aren't prevented. And so now there's a chance for even more people than we would have anticipated to be getting this childhood pneumonia and suffering these expenses, which we know from our evidence will have a disproportionate burden on the poor.
And one final, at this round, economics question for you. Are you seeing a donor fatigue or distraction problem because of COVID? So much of the pneumonia work has been supported by organizations like the Bill and Melinda Gates Foundation and others, Gavi and so on. COVID, of course, is sucking up global attention. How's that playing out in the economic end?
So I think there's an awareness on the economic end that these childhood vaccinations are extremely important. We came out with a study that showed even the risk of delivering these routine and even campaign vaccinations, this is specific to sub-Saharan Africa, during COVID, and that even taking account the risk of additional COVID spread during this time period, the returns to delivering these routine vaccinations were almost all in excess of 10 to 1 in terms of deaths averted. There's a wide awareness that these are extremely important. If you convert that into economic terms, PCV and HIB get closer to 36 to 1 returns from delivering that vaccine, even risking the additional COVID transmission that might occur for the delivery and facility visits and everything. So I think there's a wide acknowledgement that these are incredibly important and that we need to figure out how to make up for that lost coverage as quick as possible.
Okay, let's hear next from Temigiwa Tulbolson, who comes to us from Nigeria. She's the founder of Life Bank Nigeria, which delivers blood and other critical medical supplies in Nigeria and Kenya, correct? She's also now launched Air Bank, which delivers medical oxygen, of course, a critical element of pneumonia care. And we're going to start by showing you just a 1-minute video to help explain her work. I think. There we go. Thanks, Andrews. Temigiwa Tulbolson, how is the pandemic affecting the supply of oxygen in your region, especially for children with pneumonia?
Absolutely. COVID-19 pretty much stopped, critical programs in healthcare sector in developing countries. The lockdown really affected manufacturing, it affected distribution, it even affected treatment within the hospital itself.
It's in Nigeria. You had a very severe lockdown, as I recall, in Nigeria, correct? Yeah.
Right. So we had, in the beginning of the pandemic, we had a very severe lockdown where everyone was told to stay at home. Interstate travel was disallowed. It was really severe, and that had a lot of effect on the economy, on healthcare sector, on even distribution. So we are a medical distribution company. Before COVID-19, we had really focused on blood and blood products. And we saw the gap. We saw the critical gap that COVID-19 brought to access to medical oxygen. And we decided to sort of like build that infrastructure, that soft infrastructure that allows us to get to the very last mile. We use boats, we use trucks, we use motorcycles, just to make sure that we get to those hospitals and get these critical resources to this hospital. And it was the pandemic has a lot of, negative effects, but, it kind of had a positive effect on our business by pushing us to innovate for this particular resource, and also look at innovating for, vaccine distribution to ensure that we can actually get to this last mile and maintain the coaching of these critical resources while we're distributing.
Can you give us a couple of examples of the kind of innovation that you were able to come up with that might be, we've got in our participant group here, which is large and global, we've got a lot of people from other countries who might very well be able to learn and extrapolate from what you're doing with oxygen to other forms of needed supply, of course, including vaccine.
Absolutely. One of the things we first did was try to use data science to predict need for medical oxygen in these rural communities. Data, there were quite a lot of data available in these communities, but they were, on paper, and they were not being used to actually predict the need for these critical resources. So we built a tool to sort of like harness this data, literally just get the paper and fill it in and have, data entries people, and then build a sort of like a data science, a predictive model on that raw data, to basically be able to tell a hospital and say, okay, in the next couple of weeks, you're gonna need this many units of oxygen, you're gonna need this many, vials of vaccines, and then make sure that we're meeting that demand ahead of time. For us, we think that that is really, really critical to actually build a seamless, silent infrastructure for these critical resources.
And do you feel that what you're setting up in terms of delivery will be able to grow and be sustained in some post-pandemic era?
Yes, absolutely. So LifeBank is a business. So one of the things that really helps us is we've built a business model into every innovation that we introduce. We ensure that we can be sustained over time. You mentioned earlier about donor fatigue. That's a reality. And then also when there's a major emergency like COVID, the small amount of money that's available for healthcare, for supply chain distribution, will be put towards COVID-19. And then when COVID-19 hopefully is fixed, then we'll move those resources somewhere else. So it is really important to us to make sure that our work is sustainable in the long term, no matter what the donor environment is like. For us, we want to partner with donors, to be honest, to build innovation and to take that first step. But subsequently, our model is to build sustainability into the work that we do.
Great. So, and finally, as we began with the Saha, we're going to wind up with a Saha. Dr. Sanjuta Saha is a microbiologist, the next Saha generation at Dhaka's Child Health Research Foundation. Like her father, she focuses on preventable pediatric infectious disease, and she's passionate about inequities in research. Dr. Saha number 2, we have 2 Dr. Sahas. Before COVID came into the picture, what did you see as the most important task in fighting childhood pneumonia? Where were we in terms of improvement and challenges?
Right, thank you, Cynthia. So I think we have made huge progress, right? Like in 2009, we got the Hib vaccine. We almost got rid of Hib pneumonia. Then in 2015, we got PCV10, and we are seeing huge progress and impact of that vaccine in pneumococcal pneumonia. However, I think we still have a long way to go, because as we do more and more research, we are also realizing that there are many other bacteria and viruses that can cause pneumonia, which we probably still don't understand completely. So I think it's time that we invest more resources to also understand those unknown causes of pneumonia, because as scientists, we're often biased. We go after what we know and ignore what we don't know. So I think that's a large area that we still need to focus on.
And one of your specialties, implicit in the work that everybody on this panel, and I think everybody in the participant audience does, is this question of inequity, global inequity in disease burden, as well as vaccine This is a hard question to ask you because I know this is a career passion of yours, but what do you see as the most immediate inequity issue that can actually be addressed in coming months, coming years?
The most important inequity issue is obviously access to healthcare. Because this is a pneumococcal vaccine platform, let me bring up pneumococcal vaccine one more time. Pneumococcal vaccine does not only prevent pneumonia, it prevents meningitis, it prevents sepsis, and it also prevents ear infection. And a vaccine like that not only has direct impact on the diseases that are caused by this bacteria, Streptococcus pneumoniae, what it also does is it empties up hospital beds. It takes some weight off our healthcare system, and it makes space for other diseases that we are perhaps not able to prevent. Maybe it's a different cause of pneumonia, but those children with pneumonia. And I think that is what at least our group focuses on. How do we make our health system more accessible? How do we take some weight off our health system because we are struggling? Because we need to provide care to everybody. We can't prevent all diseases.
We know that the impact domestically, internationally, domestically, wherever you happen to be, and globally of COVID has not been equal. We know that the "we're all in this together" slogan has some problems. So I guess my question is, how do you see this as a kind of a body blow to the whole effort? It's going to be a very long time before a COVID vaccine is really widely available to everybody. How can you bring some hope to people who may just feel like, I've been working on this for a decade and this global pandemic has blown everything to smithereens? And I guess I'll ask you that and then throw that big question open to the whole panel as we wind up. Yes, please, Dr.
Right. I think you have kept all the hardest and the most abstract questions for me. But, there are certain things that we are learning because we are going through COVID. For example, we talk about oxygen. Our hospital gets constant supply of oxygen. But during COVID, when we were talking about oxygen, the first question or the first requirement of the doctors were, we don't even have pulse oximeters. We don't know the oxygen concentration of the children. So what we are doing is, we are now making sure all hospitals have enough pulse oximeters because they don't even know how to measure oxygen. So this is definitely things that we are learning and take forward, which I think will be very helpful in prevention of pneumonia as a whole. And then supplies, like something that we never thought about before. When you're giving a child oxygen, you need these pipes to cannulas, I think, that you put inside the nose. And often what we would be doing, because there was scarcity of these equipment, we would be using the same one for several children. And now we're realizing that's not the right practice, right? So we are ensuring that they are used safely, they're sterile, and we have enough stocks of them. So I think these are the hopes that I have. I'm hoping that all the lessons that we are learning will eventually really help us move forward for all-cause pneumonia.
Thank you. And thanks to all of you for those introductory remarks, which were very helpful. I'm going to ask the participants here. I see that there's a fair bit of comment in chat. To make things, to separate out a little bit your comments to each other from your questions, I'm going to ask that you try to put your questions over in the Q&A box so that we have a chance to kind of go through them and get your conversation into this as thoroughly as possible. As we get going on that, Dr. Klugman, I'd like to turn back to you. I know that you had a thought that you wanted to interject, and I also have a big question that I'd like to ask you. So let me start with the thought that you wanted to interject.
Well, thanks, Cynthia. So I wanted to say that one of the key advantages of pneumonia as compared to some other diseases like TB, which is really a problem almost entirely in poor places, is that these vaccines have a global market. And there is an enormous economy of scale. So in no way do we want a situation where there isn't a global market for PCB. And we're in fact optimistic that nobody is going to make a loss in this and that there is plenty of opportunity for everyone. And following on St. Judy's optimism, I want to also be optimistic about COVID. I really think this is an opportunity for COVID to alert the world of the danger of pneumonia, and that we emerge from this not where we were a year ago, and be content to get back to the level of immunization coverage and so on that we were at a year ago. We must use this as an opportunity to say that if billions, nay, trillions of dollars have been put into COVID, then some fraction of that money surely can go from rich countries into the underlying problems, the underlying disasters of pneumonia that have been going on for years and years and have never been identified as the tragedy that they are. So I'm actually optimistic that, be it supply of oxygen, be it supply of vaccines, the rollout, the unprecedented rollout of vaccine that we're anticipating for COVID surely must allow Gavi to step up and cover the gap that we have still got, the persistent gap in coverage of children going forward. So in fact, I see this as an opportunity for us to be doing better going forward, and want to work on the momentum of the exciting announcement that we do have COVID vaccines coming.
And here's a question that came up in advance and certainly came into my mind as well. And I pose this to all of you, but particularly Drs. Klugman and both Drs. Saha. What about the possibility scientifically, as well as, I guess, logistically, of doubling up a COVID vaccine, an effective COVID vaccine, and a PCV, either in terms of the distribution or of actually putting the antigens into one vaccine?
Yeah, it's not immediately a, let me just take a step back. The initial urgency for PCV, well, let's start with COVID. Who's going to get the COVID vaccine? It's the people who are putting their lives at risk every day, the healthcare workers. It's also going to be the elderly who are at greatest risk of mortality. But in the end, we have learned from PCV that in fact the best way, the best public health intervention to stop transmission of pneumococci is to vaccinate the spreaders, the kids who are, and once you immunize young children, you stop the spread in the whole community. So thinking forward, once COVID vaccine is rolled out for the elderly and healthcare workers, I think it really needs to then roll out in the spreaders. And it's in this case, not the young children. It's in fact the 18 to 24-year-olds, from what we can gather, who are out there spreading this virus. So I think we can take a lot of lessons from PCV, but I wouldn't push early on for the vaccine to be given as a combination, because there are different groups who need it.
Yeah. Doctors, I see everybody nodding. Drs. Saha, do you agree with that? This is to both Drs. Saha. This is so much fun being able to address to both Drs. Saha.
I totally agree with Keith, absolutely, that there are two different age groups and target populations, but we can use our infrastructure and lessons to make sure we optimize what we have.
And this is another doubling up kind of question, I think, for Samir Saha. And you can answer it both globally and in terms of what you're seeing right on the ground there in Dhaka and in Bangladesh. Are we seeing any evidence of COVID-required behavioral changes affecting pneumonia transmission, hand washing, being forced to be indoors, things of that nature? And I see you nodding also, Ms. Gupta, if you want to jump in here, if you see that as well.
So I mean, that we understand possibly. It will take them some time, in fact, to understand what kind of impact are happening. But I can tell you, we are not really doing anything great. I mean, if you go to Dhaka or anywhere, you'll see that people are not wearing masks, almost not even 50%. And even they're wearing, they're not really putting it in the right places. So, and then hand wash, that possibly we are really, it is improving gradually, but still, I don't think that will make a big change. If something happening, I'll be happy. But again, that will remain at a different society, not really overall. Globally, I can see that people are really coming up with the procession that, okay, why we have to wear the mask. So I think it's varying from place to place, but overall, there is a difference. So I also see a group of people, they are really having the culture that go anywhere and wash your hand and use the disinfectant. All those are okay, but not really as a whole, not in big population. At least in Bangladesh and other low middle income country, it's not like that.
I'm sorry, yes, Keith? Or
No, I was just going to say, Samir, I'm optimistic because what we're seeing is there was no influenza transmission in the Southern Hemisphere during COVID. And we don't want to lock people down in the future, but I'm really interested in this question of masks. It's culturally been part of life in Asia that sick people will wear a mask. And I think, again, with this idea of how will the future look, if we could get everybody who is sick to not go to work in the future, but wear a mask, we could probably reduce pneumococcal pneumonia transmission dramatically. We're funding a fascinating study, which I won't go into great detail, but I will tell you that at least in one of the sites, we're seeing a great reduction in hospitalization for presumed pneumococcal pneumonia during the pandemic. And we think it's because of the social distancing and maybe specifically the role of masks. So again, I'm optimistic that maybe our behavior change in the future could reduce the burden of pneumonia, even if we don't have to lock people down. I wonder what Shamir thinks about that.
I'm going to throw a couple of, well, Samir, Samir Saha, let me go ahead and let you answer that. And then I want to start bringing in a few of the questions that are popping up in our Q&A box here. You want to just let that ride, and then we'll go to a few of our Q&A questions. Okay. Okay. So taking a look at some of the questions that are coming in. Again, a lot of people are interested in Pneumococcal and its potential impact. One of our participants wants to know, would you recommend countries currently using PCV13 to change to Pneumococcal? If you do, what's the potential impact of changing to a lower valent vaccine? Are there any cost effectiveness studies to that effect? I would like to add one part to that question, which is that, as I think everybody in this participant group understands, one of the strengths of Pneumococcal for India, as I understand it, was that it is directed at the kinds of serotypes that are most prevalent in India. What does that imply for its possible spread to other places? So let's go back also to the original part of that question, which is, would you recommend countries currently using PCV to change to Pneumococcal? PCV13, sorry, to change to Pneumococcal.
So perhaps I could just say the Gates Foundation actually supports all conjugate vaccines, and we're not in the position to be saying anybody should switch from one particular one to another. So at the moment, with the current vaccines, there are 3 of them. 2 are 10-valent, 1 is 13. You are correct that the 2 10-valent are not identical. There is an important serotype included in the 10-valent from India, which was not in the original one, but all 3 have been shown to dramatically reduce the burden of pneumonia in children, interrupt transmission, and also protect against the other things that Sanjudi talked about, the ear infections, the meningitis. So at the moment, there is no drive for any particular country to choose any particular one of the 3. I think the key message we want to put out there is that they're becoming more affordable. And that's what we would really like to see. It is true that there is quite a burden of pneumococcal disease left. And so this is not the end of the story for PCV. There will be next generation PCVs, which may have many more serotypes in them. And the need for those may be greater in poorer countries, in fact, where the distribution of the serotypes is often wider than the distribution in rich countries.
Right. Ms.
If I could add to that, first of all, even in Gavi-supported countries, there are about a dozen countries that haven't yet introduced a PCB. So clearly that remains a priority and there is untapped market there. The second is that there is a substantial price reduction, here now. And with this new product, quite sort of much cheaper compared to the other two products. And therefore, as countries transition out of Gavi support, they really would want to be very careful about, how much of money they would want to spend on which product. And also when they are still being financed by Gavi, they have to co-finance, right, the vaccines. And that the extent of co-financing is linked with the gross national income per capita of every country. And I think it is a very, very interesting example, where countries would now actually take a well-informed decision about which product they want to choose. And we are getting signals that countries would want to switch products, and something that, as Keith said, we are agnostic, but we do support countries in switching to new products that may meet their needs better or may actually have some financial implications for them.
Well, given the much lower cost for the Pneumococcal, wouldn't it be in many countries' interest once it becomes available to just bail out of Gavi altogether? They don't need Gavi support for Pneumococcal, right? And a follow-up question to that, several people want to know, when is Pneumococcal expected to be available for purchase to Gavi? Do we know?
I mean, I think Pneumococcal has few other advantages. In fact, one, it is cost is one important thing, and other one also, I mean, they have the track record of really having the vaccine with low cost. I mean, think about Men-A also, one of the example what they have really cited on. But one other important thing, the most of the countries who are really gradually getting graduated, I mean, the so-called quote unquote, the graduated group, they are not really will be getting the Gavi funding. And if they don't want the Gavi funding, they should be very careful. So they will be maybe switching from their vaccine to that vaccine. And few other countries, they are having 19A. I mean, they will be maybe switching from 10-valent vaccine of GSK going to the other. So those are the important things. And I believe that Pneumococcal will be a very important thing. And I just want to see that the other industries, they are also gradually bringing down the price, because this is an example. I understand that some of the industries, the multinational companies, they are the innovative vaccines that really they're sometimes very expensive, because they are getting maybe that innovation after really failure of maybe 10 other formulation. That's fine. But at least within a couple of years or maybe few years, you should really down the price, number one, that's one way. Or you really should go to the developing countries and negotiate with them something kind of advanced market commitment. You are really working with a few European countries with a very small birth cohort. But come on, it's coming a 4 million birth cohort in Bangladesh. Just think about the other countries. It's a large birth cohort. Negotiate with them. And that is the way you'll be having your vaccine, that you can really get the price. And you'll be feeling good that you are really saving lives. And you have vaccine, and that vaccine is remaining for 15 years or 10 years, 15 years in few countries with a small number and big price. But you really sell in larger, bigger population, the vaccine will be going to the developing country instantly, in fact. So that should happen, in fact. So I think Pneumococcal or this kind of industries, they should go ahead and move forward. And that's the way they can really sell the vaccine to the developing countries. I think that's what we really campaign for it.
Brian Patino, I saw you nodding in all this. I'd like to turn that question to you, as well as switching gears just a little bit to a pollution question. But first of all, I wonder if you have looked at these the economics of this. You are a health economist with particular regard to the costs of vaccine and how that relates to its potential distribution in where it's needed most.
Yeah, so I haven't delved particularly into Pneumococcal, but I just wanted to plug that. I mean, this is the perfect situation for cost effectiveness analysis, right? Like countries should be planning as they approach Gavi transition. They should be thinking about, you know, the types of strains covered by each vaccine, what the epidemic burden is in their population, how that looks, and you know what will be cost effective. Just because something is cheaper doesn't mean it's more cost effective. It needs to be addressing the correct things in that country. You can have the cheapest vaccine possible, but if it's not covering the predominant strains, that may not be cost effective. So we really need to make sure that we're not just focused on the cost, but also the effectiveness portion of that and making an informed decision. For many countries, that may be a switch. And we may start to see, as that time starts to occur for more countries, particularly ones with larger populations that have been utilizing other vaccines, you may start to get more competition between the prices and more willingness to negotiate this type of thing because margins will be decreasing. And if you're making up, you know, smaller price with volume in some places, it may be possible, and pharmacy companies may be interested in doing that. So that dynamic has yet to be realized. The existence of the status quo largely revolves around the existence of Gavi and the lack of alternatives for a lot of those supported countries. But as that starts to develop, we may see changes in the overall marketplace.
There's a second question that's a little bit unrelated to this that I'd like to ask that may go to your study area, which is, to what extent have you been looking at pollution as an aggravating factor for all this? There's a couple of comments asking questions about that, as well as somebody pointing out that it's important to remember the connection between encouraging breastfeeding and resistance to infection. So, and of course, this has been a year of extraordinary wildfire smoke, which complicates everything, and as we know, aggravates respiratory problems. So has pollution and air contamination been part of what you've looked at?
So for us, we're mostly interested in examining what happens from the point of vaccine introduction, or for the point of either onset of illness towards end of illness and treatment, or the delivery of vaccine production. We haven't dug so much into the generation of pneumonia, like the causes of it and other ways that it could be addressed. And I think that's important. I think there's a lot of other causes that are going into this. We've dealt mostly on treatment and medical prevention, but other sociological prevention methods, environmental prevention methods are surely things that can factor into this. And I mean, it's going to be an interesting potential for case studies, perhaps in India, you know, combining efforts of reduced pollution during COVID-19 shutdowns and reduced interaction between individuals, and in other settings as well, what that looks like. And maybe some evidence can be garnered from that. But no, that's not something we've explicitly addressed. It's a bit prior to where we come into play in our analyses.
Okay.
So maybe I could step in there and say that we at the Gates Foundation are funding, together with the National Institutes of Health, a huge study with, for the first time, they have demonstrated a dramatic reduction in indoor air pollution by switching from a 3-stone fire to liquid petroleum gas, which is rolling out, you know, across India, many places. It was in fact in that study that the pneumonia cases stopped coming in with the shutdown for COVID. So that study had recruited 173 pneumonia cases, and it's been flat since the COVID restrictions. Huh. So we hope that that study will show a reduction in pneumonia in children, which is one of the primary endpoints, because it has been demonstrated already that the indoor air pollution has dramatically reduced in the arm that got the LPG, the liquid petroleum gas. But ironically, the number of cases in very young children is not going up now that they are socially distanced, wearing masks and so on. Right. So there's some irony there at the moment.
A reverse question in the same territory. One of our participants wonders, for any of you, do you think PCV vaccine has some impact on COVID-19 severity? Are there any studies on that?
I love that question. I'll let others play in here, but we have known for years that viral respiratory infections are extremely important occurring immediately before and leading to bacterial pneumonias and particularly pneumococcal pneumonia. The evidence for COVID has been indirect. One of the major indicators of severity of COVID is a protein which can be measured in the blood called procalcitonin. And high procalcitonin levels are associated with severity of COVID. Now, what may you say, has this got to do with the pneumococcus? Well, procalcitonin does not go up in viral respiratory pneumonias. It's one of the most specific assays we have for bacterial pneumonia. And so this is an indicator that there may well be a bacterial component in some of these severe pneumonias. And the vast majority of people with severe pneumonia are being treated with antibiotics. And in fact, I've just written a piece for Lancet, which came out on World Pneumonia Day yesterday, with Amy Ginsberg arguing that we have probably underappreciated the role of antibiotics in saving lives from patients with very severe pneumonia associated with COVID. So I, for one, believe that indeed secondary bacterial pneumonias are playing a role in the severe COVID cases that are in the hospital and intensive care unit.
A different question with regard to vaccine coverage, and this is again, we're very specific here, but I think a lot of the people in the group of participants are quite expert in various aspects of this. One of our participants wants to know, there have been recent efforts promoting a 1+1 schedule as opposed to the twice or 3 times coverage schedule. Would such a schedule work in most of the lower income countries where the coverage is low? Where is that conversation right now, particularly given all the problems that you all have talked about this year with regard to distribution, access, getting to people, and so on? Anybody?
Well, I don't want to dominate the conversation, but this is something that we have funded big time, because you know that the UK has switched to a 1+1. So the idea is, once you have rolled out PCV, and if you have a very low burden of PCV due to the strains in the vaccine, do you need to continue to give 3 doses to children when the strains no longer circulate, and could you go down to a 1+1?
Right.
I don't think we're ready yet to make a recommendation for 1+1 in developing countries where the data are still coming in. We're supporting studies all over the world. It is true that the study in the Gambia was actually shut down by COVID. And so that was delayed. So I think our 1+1 answers may be delayed by COVID, but it remains an interesting opportunity. Happy to have others weigh in on their thoughts on this.
Anybody else have a thought about that based on your work? Feel free to join in if something pops into your brain. Yes.
I think the Bangladesh, we will remain with 3 doses yet, because we have multiple serotypes, and then we are not really in that level that the UK can do that, because the UK, they really decreased the pneumococcal disease really very, very significantly. We are getting rid of the vaccine types, but other non-vaccine types are still remaining, but it has gone down definitely, but not that significantly that we can convince our policymakers to change it now. Yeah. I don't know whether I'll be getting another opportunity or not, but if not, then I have one more piece, that one of the question asked by you, that whether the donor fatigue issue.
Right.
Okay. So I think we have Gavi, we have Gates Foundation here, with IVAC, all of us are here. When you were talking about the donor fatigue, the COVID-19 are really making the donor fatigue to us. I mean, for many of other people, because it seems that all the fundings are going to one direction. Everything is going for COVID-19. And then, but that's not really, that's great. That should go, because that's the pandemic we have to control. But at the same time, that's not really at the cost of the other studies that we are doing, that all the other pathogens that we are having. If we are really not thinking about this, then we may have dual epidemic at some point. That may happen because we are not really knowing what's going on. And even so the Gavi is here, I can tell you, the normal surveillance that going through the WHO, that surveillance is not on. So it means we don't know even what's going on. If you ask me, for example, you were asking me the questions, what are the pneumococcal things? We don't know what's going on with pneumococcus because there is no surveillance now. There is no surveillance. And so this, I don't know what is the definition of the donor fatigue, but I can tell you that all the resources are going to one place. That should not be the case. You should take extra resources for COVID-19 and the other surveillance should go on. Otherwise, we'll be really sometimes missing we'll be missing something.
Ms. Gupta,
if I could come in here.
Yes, I would like you to weigh in on this with your international perspective, please.
Absolutely. And I think Dr. Samir Saha is raising a very valid issue. And we have been very worried at Gavi about this, that the whole sort of conversation is just so focused on COVID-19 and COVAX. And therefore, we have made sure that we continue to focus on routine immunization a lot. And I sort of assume personal responsibility for that, because what we did was to really absolutely sort of build this narrative of how, by sustaining immunization, if there is a risk of one COVID-related death, then you are saving at least 100 children lives, right? And that was the message that we communicated to countries and started to support them in restoring immunization services as quickly as possible and trying to catch up on missed children. And I can really say with some degree of confidence that in the beginning, we saw huge disruption that I alluded to. And of course, immunization was one of the worst hit services, but we also saw immunization bouncing back very quickly. So we had 68 campaigns and new vaccine introductions that were scheduled for this year, which got impacted because they were postponed or, delayed. But now we see countries moving forward with campaigns and new vaccine introductions. And that's a very, very good sign. But most importantly, the insight that I want to share here is that we are very clear that if we want to bend the curve on child mortality, whether it's pneumonia or it is other diseases, vaccine preventable diseases, we actually need to focus more and more on equity. And that is why we are bringing this new concept of zero-dose children, where we are saying in Gavi-supported countries, out of 80 million children that we aim to vaccinate every year, there are about 10.5 million children who do not receive even a single dose of the most DTP vaccine, a conversation that has never happened in the past. And what we found to our amazement was that these are only 13% children, right? So 1 in 8 children is zero dose, but they account for 50% of child deaths. So there is a moral imperative here to focus on them. And that is why, please.
This is very important. I'd like you just to unpack it a little bit for those people in our participant group who may not be as familiar with the terminology, right? So if you could just phrase that a little bit for, let's say, for people like me, who know a fair bit about this, but have not been living it full time. Help us understand what you just said in sort of more layperson language, if you would.
Okay, so what I'm sort of describing is that every year in the 70 countries that Gavi supports, we have 80 million births. So every year, these 80 million babies have to be reached with basic vaccines. Now, out of 80 million children, there are 15 million children who do not receive the third dose of DTP, which has been our key indicator of measuring access to immunization. But as Gavi started to focus more and more on equity and unpacking this whole puzzle, what did we realize? We realized that 2/3 of these 15 million children actually haven't received even a single shot of DTP.
Wow.
And once we started to further understand the circumstances of these children, who are they, where do they live, What are their profiles? Why are they missed? And it was really amazing to see that two-thirds of these children live in households that subsist on less than $1.90, which really mean that they live in extreme poverty. And now, as a result of COVID-19, where the number of people living in extreme poverty is going to go up first time in 20 years, clearly the number of zero-dose children is going to further increase. Then what we found also was that these children are living in communities which suffer from multiple deprivations. So women there do not have access to antenatal care, skilled birth attendance, contraception. And interestingly, we found that these communities do not have access to cleansing agents and water. So really, this zero-dose child concept takes us into those communities where they need immunization, but they also need a lot of other basic services. And that is why we are now sort of almost, I think, at the final stage of agreeing with our board that we would want to put $500 million in equity funding, which brings laser focus on these zero-dose children, because what I explained earlier was that though there are only 10.5 million children who are zero-dose, right? So that means out of 80 million, only 13% children are zero-dose, but they account for 50% of child deaths. So if we really want to bend the curve on child mortality, these are children and these are communities that we need to target. And it is not just a question of PCV vaccine or other vaccines, but I think it's also a question of really paying attention to nutrition, wash, air quality, other reproductive, maternal, newborn child health intervention, social welfare. And I think this is really an opportunity for us to build back better, and build resilient but integrated health systems.
Kemi, I'd like to turn to from what Ms. Gupta was just saying, Ms. Giwa Tulosan, to the work that you've been doing. Has your penetration of oxygen into these communities also helped you to see how many other kinds of resources need to be distributed more equitably besides just the vaccine in order to keep the pneumonia levels down?
Absolutely. We've seen a need for critical resources like even gloves in the hospitals, even things as simple as plasters. We've seen so much need within the health system. What Ms. Gupta was saying was really important. These are children that are forgotten even within their communities. These are children who are forced to go to the very least efficient hospitals. And for our work, what we want to do is ensure that at least critical resources are driven to these hospitals at the very last mile. So, why are they zero dose? They're zero dose because they live at the last mile. They live in places where a lot of people are not paying attention to. So one of the critical things, our goal at Life Bank, is to focus purely on how do we reach this last mile with critical resources, and how do we do it in a cost-effective way? Because if I'm moving oxygen, I can move vaccines, I can move, I can move gloves, I can move gauze, I can move everything, and then just build a silent infrastructure that gets to the last mile.
You have with oxygen, of course requires careful handling. Do the facilities that you're using to move the oxygen have the capacity to address cold chain storage and other requirements that vaccines have?
Absolutely. I mean, we started our work with moving blood, and blood requires cold chain. So we actually knew more about, maintaining cold chain during our distribution than we knew about oxygen. We had to learn that. And that came from COVID-19. But, we've now built, what we're now doing is build a one-stop shop instead of having different distribution system for all these critical resources, building one system that can move everything that's needed within the hospital, and that can get it in the right condition, and only just get it there, but even inform central authorities about those conditions using technology. We're exploring technology like blockchain to track temperature distribution of these critical resources and communicating whenever there is a temperature excursion or not, communicating critical information to central governments and to state governments who are responsible for this supply chain. So for us, what we're thinking about doing is building this silent infrastructure that just works round the clock, so 7 days a week, when there's a pandemic, when there's no pandemic, and just moving these critical resources to the last mile so we can reach these children who desperately need these resources.
So there's a follow-up question that I'd like your perspective in Africa on, but I'd like to throw it out to the other panelists as well, that a couple of people have asked, which is, do you see the attention to a COVID vaccine? How do you see it affecting vaccine hesitancy and vaccine resistance as a problem generally? Do you see it helping? Or I know a lot of people who have claimed that they're not particularly vaccine hesitant now feel like they're vaccine hesitant about a COVID-19 vaccine. What are you seeing in Africa? And then I'd like the others to chime in as well.
In the beginning of the pandemic, I think everyone thought that Africa would have the worst, would be the worst hit. We've not seen that. Of course, many people have died, and those are real human people. So I don't think we've had zero, effect. So it's had a significant effect on our people, but it's not as much as we thought it would be. So I think generally in terms of vaccine efficacy, etc., or the demand for vaccine for this specific pandemic, I'm not seeing it being significant within our communities, mainly because there's a sense that we've passed the worst one. Dr. Saha was mentioning about how people are not wearing masks in the beginning. Everybody was masking up, sanitizing, social distancing. But now we've seen a lot of those things sort of like, dialed down. People are not wearing their mask anymore, or when they wear it, they would not wear it properly and put it under their noses. So I can see that happening with the vaccine as well. But I think what really matters with vaccine is explaining why vaccines are so critical to this community. And also, I think a lot of times people who live in these communities feel that you're mentioning COVID, and you're bringing this COVID vaccine to us. But, my kids are dying of pneumonia. My kids are dying because oxygen is not in the hospital, and they're dying of malaria. And, I don't care about COVID-19. So I build, equity, like, Ms. Gupta was saying, we need to build equity into the system. And we really need to focus on the concern that these communities have, and not over push COVID, but make COVID part of, make any vaccines for COVID-19 part of a routine healthcare delivery.
Right. Any other thoughts on that? Sanjuti Sahai, I see you nodding vigorously, and I know that, of course, inequity has been one of your driving themes.
I'm nodding because I'm totally agreeing with, Ms. Gupta and Tammy. It's so important that we not only focus on vaccines, which is definitely very, very important for prevention of diseases, but we have to remember that historically, many developed countries have eliminated many diseases before vaccines, right? Like we talk about typhoid, Dhaka, like it's almost passage of right to, have typhoid, and you're not a human being or a Bangladeshi if you haven't had typhoid. And we are, of course, right now advocating for the typhoid vaccine, but typhoid once ravaged streets of New York or big cities in UK, but they got rid of typhoid way before vaccine. So I think it's so important that we focus on WASH, we focus on basic access to healthcare, and all of us need to come together to really push this equity issue forward. Just, us only advocating for vaccine will not go that last mile. That's why I'm vigorously nodding, yes.
Yes.
If I could
hang on. First, other Dr. Saha, please. Yes.
Yeah. I think, especially Bangladesh is different. They are really waiting for vaccine like anything, but unfortunately, we also should mention to them that this vaccine will be not really like HIV vaccine or other vaccine will be just eliminating the disease. So
wait, just to clarify, are you talking about the COVID-19 vaccine whenever it becomes...
the COVID vaccine, everybody is interested. We are just a little afraid when the vaccine will come. we planned that who will be getting first and who will be getting second, who will be the third. But we are just afraid that the influential people may take the vaccine from them, and possibly the people who are supposed to get, they will not get it. That even can happen. But that is one. But at the same time, I think we should start talking about now what Shriti was also talking about, that this vaccine will not be enough really to protect. We have to continue to use masks. We have to continue to do the hand sanitation, everything. All these has to be together. The vaccine itself will not save us, in fact. So even today, in fact, I saw that even the German who are really part of the Pfizer, working with Pfizer, they're saying that whenever they will be getting even the 90% efficacy of the vaccine, still they're advising to continue, when the vaccine will come, to continue follow all those mask, hand cleaning, distance, everything. So, but I can tell you, I think compared to this, any other vaccine, hesitancy is very, very less for COVID because people are afraid. I hope some of the people will be forgetting the vaccine hesitancy by this time. That's what I'm expecting, in fact, at the end of the day.
So as we move into the closing 10 minutes of this very helpful and interesting panel, I'd like to ask you to help the participants by turning your thoughts to what happens next. We obviously don't know how effective this new COVID vaccine will be. We don't know what's going to happen 6 months from now in the pandemic. But our audience includes a number of people from NGOs, from health ministries, people who have deep experience in this, and they're from all over the world. What do you all advise in terms of both messaging and action that people can think about taking during this dreadful year as they try to cope? I guess I'm going to ask, and we'll start. I'm going to hold your thought, Dr. Samir. Is I'm going to start with Brian Patenaude, based on what you've seen, and then we'll round up. But as you're giving people ideas for what their own ministries, agencies, etc., might bear in mind on World Pneumonia Day as they go forward, what would you suggest?
I mean, I think one of the most important things is the realization that we need to be delivering these other vaccines, even in the state of the pandemic. Yes, we need to think about a COVID-19 vaccine in different settings and how to roll that out, but we can't extend the disruption that is existing in other vaccinations, including those for pneumonia. We need to figure out how to safely roll those out and make sure that we're not putting levels back to lower coverage for longer than we need to. These don't just have the health implications that we all know they do. They have huge economic implications, which are exacerbated by COVID. So even from an economic standpoint, also, these are more important than ever to be rolling out. And so countries really need to figure out ways to prioritize scaling routine and even campaign delivery of vaccinations up alongside the discussion with COVID, and make sure that those things aren't forgotten or put off until after the COVID pandemic is dealt with. So I think that's the number one thing I would say.
Ms. Gupta, I'd like to turn that to you. I can imagine, I'm trying to imagine being someone in a health ministry in, say, a middle income country right now, listening to what Brian Patenaude and all of you have said and knowing what I would know and just tearing my hair, saying, how can I do this? I have limited resources. We're in an extraordinary, unprecedented pandemic. The world's resources are limited. What the heck do I do? Especially if I'm a middle income country and I have the prospect of graduating out of Gavi support. I'm not asking you to fix the world's problems, Ms. Gupta, but what would you suggest as some of the messages they might carry forward?
Yeah, so first of all, I think our message now is to focus on collateral damage of COVID-19. So, as the countries are very taken by the pandemic, not taking their eye off the knock-on impact, because, that is creating more difficulty. And the second is this whole conversation about equity, because the pandemic has actually hit the poorest the most, and inequities have further deepened. So I guess, there is a choice to be made here, whether we want to move from center to the periphery, or we really want to now focus on periphery and from periphery to move to the center. That means people who are really living on the margins have to be first covered. And then from there on, you start to move towards better off populations. So I think typically we think about these populations living in very remote areas. That is why we say it's the last mile delivery challenge. But I do want to remind us that a lot of these people are also living right under the nose of the governments, in the urban slums of capital of the national capitals. So really the number of children that are marginalized or that are falling off the routine services actually are living in very crowded spaces in urban and peri-urban areas. And it is not hard to take services to them. So we typically find children and communities here in urban among the urban poor, remote rural areas, but also fragile settings where we have active conflict and services really are extremely weak. So I think that's one. The third thing that I would say is that therefore making sure that we also prioritize prevention. So countries really now are under a lot of fiscal stress, and both the finance and health ministers have to really make some very difficult choices in terms of allocations, right? How do they allocate public financing? And that is where supporting countries to make good decisions, and actually prioritizing prevention over treatment is an important decision to be made. And that is why vaccination has such a strong case, because, you are actually preventing diseases. And for example, we talked about the hospitalization costs, for children who suffer from pneumonia. And of course, the poorest cannot afford those costs. So in the poorest communities, children die. And in other communities where you are able to save children with treatment, there is catastrophic medical expenditure. So I just think that this is a message that we have to continue to reinforce. So prevention and then equity in prevention, then I think it would hold all of us in good stead.
Bolson, what do you give our participants as a send-off message to help them focus what they're doing and think about what may be coming at us in the next year?
Right. I think that, like everyone has said, Brian, Gupta, the Sahas, Dr. Klugman, everyone has mentioned. I think for us, what we need to do is build a resilient system, a system that can still continue delivering critical resources, vaccines to the last mile, even within the context of a shutdown during a pandemic. And that requires actually thinking through it, building that system up front, and creating that infrastructure by partnering with maybe private sector businesses like LifeBank, but other systems that can still continue operating within a pandemic. I remember earlier that someone said this is the pandemic age. When COVID is done, another one will come up. So it is really, our responsibilities to start building resiliency into the sort of like the public health work that we do, and then and building that plan so that countries, particularly lower middle income countries, are ready for when the next pandemic comes.
Yeah, Dr. Sanjyoti Saha, what are you going to be concentrating on in the next 6 months? Watching what happens as the pandemic does whatever it's going to do with regard to pneumonia and children's diseases?
Cynthia, I think I'm going to pull back the first question that you asked me about the optimism or the lesson that we are learning from COVID-19. And I think there are a lot more things that we have learned, which I definitely did not emphasize at the beginning. And I want to take this opportunity to do that. On the 8th of March were the first 3 cases of COVID detected in Bangladesh. At that point, there was only 1 lab testing in Bangladesh. Today, there are more than 100 labs testing. I think that's phenomenal. These are labs who have built capacity for diagnostics. They have gotten qPCR machines. And all of that has happened because we got amazing funding from international and local donor agencies, right? I want to see us continue. COVID-19 today, tomorrow, next year is going to go. But our backdrop of other diseases are not going to go anywhere, and we have to continue dealing with them. I want to ensure that we use every infrastructure that we have built, that they don't gather dust. The second thing is genomics. As we progress in understanding pathogens more and more, we are realizing the importance of molecular biology, the importance of genomics, and being able to sequence locally and not shipping out samples. Our country has never sequenced RNA viruses because, usually we're just sending them out to our collaborators in the global north. But this is a time when everyone was busy with their own samples. Only we cared about ourselves, like selfish people, right? We figured out how to sequence. We have sequenced about more than 500 SARS-CoV-2 in Bangladesh. That's unbelievable. I want to see this go forward. I want to sequence pneumococcus in country. I want to sequence all bacterial pathogens and viral pathogens in country. I want to keep this going, this passion, this dedication going. And the third thing and the final thing came up again and again. Are we going to switch to a new vaccine? How do we know the effect of pneumococcus on COVID-19? I think the basis of all of that is surveillance. We have to ensure that we continue surveillance, we build capacity and infrastructure for surveillance, and every country needs to have really good surveillance to go forward with data, to make decisions based on data. We are learning how to do surveillance with COVID-19. We are building infrastructure. The donors are realizing how important surveillance is. Gavi is realizing how important surveillance is. We need to take this forward and keep going.
Wonderful. Are you gonna try to follow on that act by your daughter, Dr. Saha? Samir Saha?
Thank you. So I'll say that with this COVID-19, when we are talking about, and possibly, yes, we need to focus on that. It's very important, but I'll say that we should not ignore other pathogens, in fact, who are causing disease. Otherwise, sometimes they will be emerging in a way. And some of them are like, when we're talking about pneumonia, I mean, in addition to this COVID-19, I mean, the Pneumococcal, who are all the other vaccine preventable pneumonia cases, but we also should keep in mind that what are the other organisms which are causing pneumonia. For example, RSV. I mean, it is the game changer. In fact, if maybe some people are not really talking about RSV much nowadays, because we are talking about the one virus now, and we are really focusing on that. I'm really getting concerned with this, because once the RSV vaccine will come, it will be the game changer. And then we should really also think about this. And also surveillance. I'll be talking about the surveillance again, because I'll be adding that one more time. If surveillance should be cost effective, and I think we need to discuss about the donor and also the people who will be doing the surveillance. We really misuse the resources sometimes. For example, we did the surveillance of Pneumonia. We were together. We are not really smart on those days. And then with Pneumonia, when you're doing the pneumococcal surveillance, but then you have one more study, Hib initiating, Haemophilus influenzae type B. How come you are only doing the pneumococcus? Are you not really isolating the Haemophilus influenzae type B also? And can we not really do the little bit of addition? You can really leverage typhoid with that. Can we not really leverage the other organisms on that? Can we not make a surveillance like this, which will be really leveraged properly, quality surveillance, and that will be the cost effectiveness. You don't need to spend a lot of money. That's one important thing. I think if we can do this, we will be knowing what is coming next if the surveillance is going on.
Thank you, Dr. Samir. And I'm going to ask you, Dr. Keith Klugman, to wind us up in terms of what are the messages that people ought to carry forward in these interesting next 6 months that are coming?
Well, thanks, Cynthia. We at the Gates Foundation are optimistic. We're impatient optimists. And so here's my optimistic message going forward. We don't know yet whether the first generation of COVID vaccines will interrupt transmission, but there is a good chance that they will. There are data from these vaccines that they can impact transmission in animals, and I think we will know. If they do, then there is enormous excitement going forward. The advanced market commitment we talked about, the transformed PCB, has been recreated for this problem. So the COVAX advanced market commitment is getting billions of dollars together to make vaccine available for the whole world. And the key to us ending this pandemic is for the whole world to embrace their neighbors. The reason that you want to get this vaccine is not just to protect yourself. It'll then be to protect everybody else. While we were sitting here, someone came to fix our fridge just before we started this program. And I put on a mask. It's my own home, and I put on a mask because I wanted to protect the person coming into my home. So I think that that's the right thing to do. And I see a world in the next few months which massively embraces this vaccine to stop transmission, which is the only way that economically the world can move forward again. So that's my optimism for the future for the next few months.
And that's a wonderful send-off note for us. Thank you all so very much for your participation and getting up at all kinds of odd hours all around the world. Ditto to the participants who have joined us with their interesting questions and comments. The chat, I know, has been very lively. Again, this whole session has been recorded. So if any of the participants or the panelists would like to pass it on to others who may want to listen and profit from it, please do. Thanks again to IVACS and Johns Hopkins, and I hope you have a fine morning, midday, or evening, wherever you may be in the world. Thank you very much.